So, dear colleagues, let's start with Dr. Ibrahim for the sake of the time. Let me remind you again with the topics of tonight's webinar. We are going to start with Dr. Ibrahim. Dr. Ibrahim will talk about causes of hearing problem in children. Then Dr. Alobna, hopefully that she will join us and talk about hearing assessment. And then finally, Dr. Hussam will talk about introduction to the cochlear implementation for the patient. Dr. Ibrahim, tfaddal, floor is yours.
Okay, good afternoon, good evening, everybody. So the last 15 seconds was just to remind you how important is audio and how hearing is important for all of us. So that's why this topic is very important. Hearing actually opens walls. It removes barriers from people. It makes life easier for everybody, especially for children. So let's start from the beginning. This is me, Dr. Ibrahim Isa. I'm going to speak about the causes of hearing problems in children today, and I will just give a glimpse about the management of hearing problems in children. This lecture will be designed mainly to the level of health professional, especially people who are not specialized in ENT. Most of the information in this lecture will be known for ENT people. Hopefully, it will be something good and informative for non-ENT health workers. We will start discussing the causes of hearing problems in children in a simple fashion, and then during that, we will discuss some management parts. So in order to understand the hearing of somebody, especially children or adults, if you want to hear something, you have to have the sound coming from the external ear, from the auricle, from the outside. Then it goes into the ear canal. Then it reaches the eardrum. The function of the eardrum is to transmit the sound to the middle ear and amplify the sound. So after that, the sound will go in the middle ear cavity, which is a cavity filled with air. This air comes from the Eustachian tube, and it contains ossicles that also amplitude and transmits the sound to the inner ear. So any problem in this area will cause conductive hearing problem. If the problem in the auricle, ear canal, eardrum, or the ossicles, or even the cavity itself, if there is something blocking the cavity, causing problems in the movement of the ossicles, it will cause conductive hearing loss. So the sound will not go to the cochlea. Then after that, the sound will go or be transmitted to the cochlea, which function as a transference or a transmitter of the sound from the mechanical waves into an electrical waves to go to the nerve and then the brainstem and then the brain, where you can hear and understand the words of the people, of the world around you. So any problem in the nerve or in the cochlea or in the inner ear will be assumed as sensory or neural problem. So simply in this lecture, we'll go through these parts, the external ear, middle ear, and inner ear, discuss what kind of problems might happen in this area, and then these such problems can cause hearing problems or deafness. So firstly, the ear canal and the pinna. The outer canal, if there's anything blocking this cavity, it might cause problems in hearing. For example, in the pictures in this slide, there is something called microtia or canal atresia, which is deformity of the ear canal. It might be just simple as some minimal changes in the auricle, or might be grade 2, 3, or 4 extensive deformity of the auricle, ending up sometimes with complete absence of the auricle. And this usually it's not just a cosmetic problem. Sometimes it's just a cosmetic problem causing closure of the ear canal, which causes just conductive hearing loss. But in most of the cases, it's also associated with some other congenital problems that might happen in the middle ear and the inner ear. So you have to dig in and see if the patient is having, like by doing a CT scan and MRI scans to know if the patient has any middle ear or inner ear congenital anomalies associated with this microtia. Other more common things, simple foreign bodies. Many foreign bodies can go into the external canal of the child, cotton buds, plastic pieces. Anything that blocks the ear might cause some infection and cause blockage of the sound. Sometimes, commonly, the wax impaction in the left screen picture will cause hearing problems. simple removal of these foreign bodies will improve the hearing in such patients. Other thing is inflammation, infection of the external ear. It's either simple discharge in the external ear, or sometimes extensive narrowing of the skin of the external ear might block the sound from going into the middle ear, and this simply will cause hearing impairment, which is conductive and temporary problem. Treatment of this either by antibiotics or by antifungal, depending on the cause of the infection, will cure usually the problem and improve the hearing. So then after the voice comes from the external ear to the middle ear, it goes to the eardrum and the ossicle. So what happens next, if we have any problem in the middle ear, it might also cause problems in hearing. So simply and very commonly, the otitis media, inflammation of the middle ear, when the patient is having severe ear pain, sometimes with fever, usually it's preceded with upper respiratory tract infection, some nose block. This will cause accumulation of pus inside the middle ear cavity, and this pus will prevent the movement of the air and movement of the eardrum, and also will decrease the movement of the ossicles and causes hearing impairment. Treatment of this is simple with antibiotics and some decongestion of the nose to open up the sacking tube and remove the fluid from the middle ear, which will just aerate and transmit the sound easily again. But sometimes this doesn't go completely. Sometimes this fluid stays in the middle ear, either due to chronic problem in the middle ear, chronic problem in the nose, like adenoid hypertrophy, chronic allergy, nasal polyp, postnasal mass. Anything that can close or obstruct the sacking tube will prevent air from coming into the middle ear, which causes fluid accumulation in the middle ear. This fluid is not infection, it's not pus, it's just a sterile fluid that accumulates in the middle ear. Does not cause pain, but it's a silent cause for ear for conductive hearing loss. So the patient will not be hearing easily simply because there is no mobility, no normal mobility of the ossicles and the tympanic membrane. And in such cases, usually the treatment is with just observation, treatment of the cause of the nose block or the sacking tube, and sometimes we need to do ventilation of the middle ear by doing a grommet tube, a simple tube that is put in the eardrum under general anesthesia, usually in children, to ventilate the middle ear, get the air back inside the middle ear, and suction the fluid from the middle ear. So it will help the movement of the eardrum and the ossicles again and improve the hearing of the patient. Okay, other causes is the perforation of the tympanic membrane. As you see in this picture, the tympanic membrane is perforated, either traumatic perforation or due to chronic infection, and obviously this will cause decrease in hearing because the eardrum is important for conduction of the sound to the middle ear. Sometimes this perforation is just not just a simple perforation. Sometimes it's associated with chronic ossicular problem, chronic suppurative otitis media, sometimes middle ear masses like cholesteatomas, chronic infection. So then the treatment is not as simple as grafting the eardrum. Sometimes we need to remove the ossicles, remove the chronic infection, clean the mastoid cavity from cholesteatoma or chronic infection, and rebuild the ossicles with ossiculoplasty and graft the eardrum. So it's very important to clean the infection in such cases to prevent damage of the middle ear further in the child. Okay, other thing is the congenital anomalies of the middle ear, which includes usually congenital problems in the ossicles, and mainly when we're speaking about congenital problems in the ossicles, we are speaking about fixation of the stapes, the third ossicle, the most medial ossicle and closer to the inner ear ossicle. It could be just a solitary problem of the stapes, but sometimes it's more severe and more related to a more generalized syndrome or congenital anomaly, such as osteogenesis imperfecta, Down syndrome, Treacher's column syndrome, and very important in such cases when you are suspecting a problem in the stapes, that it might also be related to a congenital anomaly also in the inner ear. So you have to be cautious while doing audiometry and assessment of the hearing of a child with a middle ear problem. You have to dig in and see if does he have another problem in the inner ear, or it's just a solitary problem of the middle ear. Okay, then finally the inner ear. So if the air or the sound goes from the external ear then to the middle ear and normally goes to the inner ear, then the inner ear has to function by transmitting the sound, transferring the sound waves into electrical waves. It does so by having the cochlea. The cochlea is a bony structure that has inside it what's called the perilymph or endolymph, or we can call it the organ of corti. It's actually a membranous cochlea, the part that is functioning inside this bony cavity. So we have to have two things normal. We have to have the bony cochlea normal, and also we have to have the membranous cochlea working and functioning normal in order to have a good hearing. So it's not the shape of the cochlea only, but also the function of the cochlea. So sometimes the problem is the congenital anomaly that causes sensory neural hearing loss, either autosomal dominant or autosomal recessive problem. It will cause sensory neural hearing loss. Sometimes it's only isolated sensory problems, or sometimes it's associated with a syndrome, like a congenital problem. The patient has more dysmorphic feature, and one of the symptoms that he is having non-functioning cochlea, so he will have also sensory neural hearing loss. So it might be just congenital. Other causes, it might be intrauterine problems. So during the intrauterine life, if the pregnant mother has got some infections like rubella infection, or if she's taking chemical teratogens, or was exposed to radiation, for example, this might increase the risk of cochlear problems in the child that she will give birth to. And sometimes, even after birth, these problems can happen, like having a chronic fever, severe increase in temperature, meningitis, for example, inflammations in the meninges might cause labyrinthine problems. Usually, this is typical to have after severe meningitis. Children might have ossification of the labyrinthine lumen. So then you have to be cautious before doing even a surgery like a cochlear implant. It might not be easy to insert the electrode in an ossified cochlea. So in order to understand the congenital anomalies in the cochlea, you have to know that the cochlea during the congenital embryologic life is just a sac. Then this sac expands, and then it starts to have the anatomy of it, the semicircular canal, the vestibule, and the 2.5 loops of the cochlea. In this bottom part of the picture, you can see 2.5 loops of the cochlea. It should be normally complete cochlea to have a very good normal hearing. But some patients will have just a single cavity, like in this 33 days. Sometimes it's not enough looping of the cochlea. So this will affect the treatment, and this will affect the type of electrodes that might include. And Dr. Hassan will speak in a minute about the cochlear implant. The cochlear implant is introducing an electrode inside a normal cochlea, a normal anatomy of the cochlea. It's not functioning, but it's normal in anatomy. So if it's not normal in anatomy, sometimes we'll not be able to insert a cochlear implant. We might go further and do something like brain stem implant, for example. Okay, so the malformations of the cochlea, the membranous labyrinth, it could be the cochlea could be just a membranous problem, or could be a bony problem, or could be both. And this problem could be associated with a syndrome, or could be isolated sensory neural problem. So either the cochlea will be absent completely, cochlear atresia, or be hypoplastic, malformed and not enough-fully formed, and sometimes it's not complete partition, so there is no complete 2.5 turns, and sometimes it's just a common cavity or even ossified. Okay, so for the group of people who are hearing me, from nurses, other health professionals, general practitioners, or even specialized doctors in other specialties than ENT, this might be the most important slide in this lecture, is when you have to think that this patient should be transferred to an ENT clinic or to an audiology clinic to assess his hearing or her hearing. When you think that this child, your child or your friend's child, any child in the family, any child that comes to your clinic needs an assessment for hearing, what red flags you have to think of to think that this child might need assessment of hearing? Firstly, the family history. The child has a family history of a neural problem or hearing problem. If there is history of prenatal maternal medication use, teratogenic maternal medication use. If there is a history of neonatal ICU admission, this is a very important risk factor that might cause the patient to have a sensory neural problem. If there is prolonged fever or meningitis. Any patient after severe meningitis should be assessed by an audiologist and an ENT to be sure that he or she doesn't have like a sequelae of the meningitis, like hearing problems or sometimes cochlear ossification. If the patient is syndromic, the child is syndromic, there is, for example, congenital anomalies, facial deformities, it's crucial to assess the hearing and assess the ear if there is any congenital anomalies also associated to the ear. If the child has delayed speech, also one of the main causes of delayed speech is simply because the patient doesn't hear. If you don't hear, you'll not be able to speak. So it's very important in delayed speech cases to be assessed by an ENT and an audiologist. If the patient has psychological problem or neurological problem, also it's very crucial and important to assess the hearing as part of this neurological assessment. And also if the patient has recurrent ear infection, as we early in the lecture spoke about the otitis media and serous otitis media, accumulation of fluid in the middle ear, usually this patient will present with recurrent ear infection, so you have to know that he's having fluid accumulation in the middle ear, and it's easily treated thing. If the patient is having poor school performance, also it's very important to know that this poor school performance is not related to poor hearing. And last thing is that every time you have always to think when you're looking at your child that there's both ears. So if the patient or some child is hearing well, this does not mean for sure that he's hearing in his both ears in a normal fashion. So sometimes the patient is hearing in single ear, and it's not diagnosed till like 10 or 15 years of age. So you have to be sure that he's hearing in both ears normally. So the take-home message from this lecture is you have to early detect the problem, because sometimes if you detect the problem, it's easily treated. And if you don't detect the problem, it will continue and make complications, and it will cause problems to the patient that will be you will not be able to treat. For example, Dr. Hassan will speak about the cochlear implant. Cochlear implant, if it's done before the age of 3 or 4 years, it's a very successful surgery. But if you delay it, for example, after 10 years, it will not give a good hearing for the child, and he will not have a normal life, not have a normal education. So if you early detect, you will early diagnose, you will early treat. Otherwise, you will have a child with delayed speech, poor education, poor lifestyle, poor future, and complications. And then after that, you will limit your hands. You will limit your options of treatment. Thank you very much.
شكرا يا دكتور، جزاك الله كل خير. Thank you very much. Would you please stop sharing? دكتورة لبنى.
Today I will give a brief summary how to do testing, hearing test in children from day one. كان في هنا picture auditory pathway بس خلاص هودي الموضوع ده. The function of auditory system it is consists of two ways of peripheral pathway and central pathway. The peripheral pathway is important for transmission of hearing signals, also what we hear, and the central processing. It is important to understand what we hear. This is the cognitive or higher function ability. The range of hearing we have the sound. The sound is consisted of frequency, which is different pitches we hear, and the intensity, which is the loudness of the sound, which ranges in the human from the frequency from 20 to 20,000 hertz, and the intensity from 0 to 1 to 120 decibel hearing level. This audiogram shows the familiar sounds we can hear during our daily activities, and we can see here at the x-axis, this is the different frequencies of different pitches from 250 till 8,000, and this is the loudness from 0 decibel to 120 decibel, and as we see the different sound pitch located in this area, which is called sound pitch banana, which is important for the ordinary speech and language community. So what is the definition of hearing loss? The hearing loss is hearing loss or diminution of hearing sensitivity more than 25 NHL in from frequencies to 60 till 8,000 Hz. This can be this is the frequency range as determined by ASHA, which is American Speech Hearing Association, in 1968. In the adults, we can consider it hearing loss if it is hearing threshold lying above 25, but in the children, we have a lower limit. That hearing, we consider it hearing loss if the hearing is worse than 15 decibels. So what are the degrees of hearing loss? We have different degrees. The normal hearing lies, as I said, from 0 to 25 in adults. In children, until we consider it slight hearing loss if it is more than 20 Hz. More than this, 26 to 40 decibels is mild hearing, then moderate hearing loss, then level for moderately severe, then severe and profound. What are the types of hearing loss? We have two types of hearing loss. Peripheral hearing loss, which consists of conductive sensory neural omitted hearing loss, that's according to the etiology in the peripheral hearing system, and central auditory processing deficits, which when there is affection of central pathway. So we have, sorry for the picture is distorted here, but we have conductive hearing loss if the outer auditory external ear canal or middle ear affected. Sensory neural if we have affection in the inner ear or auditory nerve. Mixed hearing loss if we have combined affection of outer middle ear and inner ear. So what is when the hearing loss occurs in the children and infants? It could be during the perinatal or prenatal, perinatal or postnatal period. So according to the timing, it affects each timing would affect the ability of the child. So the impact of hearing loss would be delayed in speech and language development if it occurs early in life. If it occurs later, it could affect also the hearing, which would lead to learning problems, or then this affection will lead to behavioral and social problems. So we have to know that the critical period of language acquisition lies from birth to 5 years, so the auditory signal can be optimally received. So we have to interfere as early as possible if there is hearing loss before 5 years age. So the objective of hearing evaluation have many. For hearing evaluation, we have objectives to do. We have to define if there is a presence of hearing loss or not, if there is what is the type and degree of hearing loss, and the possible etiology as well, and then to measure this hearing loss on the verbal communication so that we can do the proper management. The hearing evaluation, the diagnostic evaluation, I divide it into two ways. First, we have to early detection of hearing loss through hearing screening, through newborn hearing screening and school screening. And also, the second stage is diagnosis of hearing loss in the secondary and tertiary hospital, which necessitates the sound control facilities and audiological equipment. During neonatal period, we can, in the first 2 days of life, we do newborn hearing screening, so by using automated ABR or Otoacoustic Emissions. And later in life, after 5 or 4 or 5 years, we do periodic school screening through day or your tone audiometry. Whenever we see any failed infant hearing screening or failed screening in older children, we should go further for confirmation for this hearing by doing the thorough hearing test. Here we see that in neonates we can use either Otoacoustic Emission, and this could be failed in the first 2 days of life, but we have to repeat it again as in the first month of life. If it is we have to go further diagnosis by using ABR. Not, we have not to delay the hearing assessment by at least 3 months of age, by maximum at 3 months. By auditory brainstem screening, also the similar idea, that is another instrumentation, but in this case we have pass or fail criteria, and we have to repeat it again if it is not passed, and we have to do full diagnostic ADR by the age of 9. For the full package of hearing assessment, which includes history, general examination, ecological examination, objective testing, or subjective testing. Objective testing using electrophysiological tests, or subjective, which is they are behavioral testing, or and speech audiometry, and also Tympanometry. Why we do here history? The history, when we suspect hearing loss from the history, if the child has if there is a history of high risk neonatal intubation in the ICU, or familial hearing loss, or there is any another syndromal hearing syndromal anomaly. Also from history, parents can report that the child has lack response to sound, or there is a delayed language development or speech effect, and also there will be educational. From general examination, we will see head and neck focal brain pressure anomalies and other systems for other systems affecting syndromal hearing loss. Logical examination, you can see also the ear anomalies or any kind of acute or chronic atresia. The test battery for diagnosis includes electrophysiologic or for detection of the hearing threshold level. We can use electrophysiologic or behavioral. Electrophysiologic, we need it when we need it, when the neonates fail the hearing screening test to confirm hearing loss before the age of 3 months, or any children or infants unable to do or operate for other behavioral testing, or we commonly use the ABR as a gold standard in the first 2 years of life. For the electrophysiologic test, we have two main testing, or ADR, or auditory brainstem response, or otoacoustic emission. The otoacoustic emission, it needs special instrumentation. It is a physiological test that by measuring the outer hair cell, which respond to presentation to sound stimuli. So as we see, we can see that there is continuous generator which goes in the outer ear canal to the inner ear. The inner ear will respond by another sound which will be picked up by microphone and amplified, so that we get a signal. This signal is frequency. We can analyze it into different signal frequencies, and also we can examine each ear separately. We can, according to the testing signal, we can classify into transient or distortion product of acoustic emission. The result usually either the child has normal hearing or he has hearing impairment, but we cannot know precisely which threshold. But so that the otoacoustic emission would be a useful test for rapid detection of hearing loss or absence of hearing loss. It has also limitations that the child should be inactive or during the testing, and the otoacoustic emission is sensitive to effusion or cerumen or vernix inside the ear canal. That simply, if there is wax or any occlusion, you will not have you will have fair results or absent response. Also, it measures the cochlear function, so that we can miss the cases when the auditory nerve is affected for other neural anomalies, such as auditory nerve. Auditory brain response also needs special equipment. The child should be lying in a comfortable chair or bed, and it also requires that he is to be too quiet, either in sedation, under sedation, or natural sleep. Each R is specific. Each R can be, ear could be tested alone with frequency specific. We test along different frequencies, and the measurement gives us good threshold, measure hearing threshold, and also it gives an insight about integrity of auditory brainstem pathway. And here, as we see, the response of auditory brainstem, we give stimulus, the child is sleeping, and we give a stimulus through the insert bone, and we pick up the response through the exposed from the head, and the result will be the auditory response waves. As here, as we see, it consists of 5 waves. We can detect threshold by decreasing the stimulus level until the minimal level we can see the response. This will be the threshold complete. In addition, also that the child should be sleeping or quiet, so that it is not easy to do it unless we have sedation. This recording very sensitive to electrical and environmental noise interference, so it has to be in either in soundproof room or that there is a good shielding for the equipment. And also it measures the auditory integrity and the brainstem and dual abnormalities. But if the child has normal cochlea and absent response, we could misinterpret as severe hearing loss while his cochlea is normal and auditory.
دكتورة لبنى؟ دكتورة لبنى سامعاني؟
سامعة.
3 minutes remaining يا فندم.
خلاص أنا عرفت. Behavioral testing are measuring responses to child to speech or frequency stimuli to this threshold of hearing by different which is age based. According to the age, sound field testing from 6 months to 2.5 years, audiometry from 2.5 until 4 years. After 5 years or more, we can do voluntary or conventional threshold. As you see, we need for this testing soundproof room, and the testing subject, the doctor is sitting outside by this instrument, and inside will be the patient or the child we are testing in the soundproof room. In the sound field, we have the child is sitting on the lap of his father or the table, and we give him sound stimuli from 2 sides. And the child will respond either by prior vocalization sound or stop movement or anything. We can see his behaviors, and this condition can be we do visual reinforcement so that we can reinforce him to look at the sound when we give him the gift or playing toys or a lighted video. But it has a limitation that only assists the better ear in the sound field. Play audiometry for the older children. We condition the child that when he hears the sound, he should drop the block or when he hears the sound. But it means that it has a difficulty in when there is attention span affected, the child will be limited information taken from the child. Conventional audiometry, the child has to raise his hand or when he hears the sound or click on the button, but this also depends on the child's understanding and cooperation. So the second testing is speech audiometry. It is a measurement of subject communication and ability to use speech material. We can use speech for detection threshold, his threshold by using speech materials like words until we give high sound with different words, and we see which level he can minimal level he can hear the sound and repeat. Also speech discrimination scores, this using different speech material for children. We can by which we can know which ability to communicate or his speech language. Finally, tympanometry is an objective measure for middle ear. It's not a hearing test, but we measure the function of the middle ear so that we can know the atresia or to exclude atresia of middle ear section. And as we see, we have different different figures for tympanometry or tympanogram, either normal, which was type A, type B if there is middle ear fluid, type C if there is affection of second tube or starting of affection of middle ear function. Final important notes to take that the evaluation of hearing of the children is a comprehensive test strategy tailored according to the child's age and his cooperation. And the audiological assessment is not a single timing. We don't have the threshold and stop. We have to do regular audiologic re-evaluation to determine if there is fluctuating or progressive hearing loss. Also, the middle ear function is important to be monitored if the child has frequent or recurrent middle ear affection, so that will not affect further on the long run affect his hearing on the long way. Thank you.
شكرا يا دكتورة، جزاك الله كل خير. Thank you for your presentation. دكتور حسام، اتفضل. Now dear colleagues, let's go with the third speaker, Dr. Hussam. Dr. Hussam will talk about ocular implantation. اتفضل يا دكتور.
السلام عليكم ورحمة الله جميعا. أيضا أولا أعتذر عن التأخير اللي صار، ولكن إن شاء الله I will try to rush through this presentation. Especially the first part was covered nicely by Dr. Ibrahim and Dr. Lubna. So again, my name is Hussam Amoudi, otolaryngologist.
دكتور حسام، بعد إذن حضرتك لو ممكن تكبر بس السلايد.
صح مظبوط. شفتي كده تتحمست خلاص ببدأ.
أيوه كويس.
ما هي راضية تظبط معايا لحظة واحدة هنا.
من تحت، إيه رأيك؟ جميل جدا، يلا جو. يلا.
My talk today about cochlear implant as an introduction as a treatment management for deaf kids. When it comes to cochlear implant, it's actually my passion because this is one of my probably favorite surgery, and you'll know why by the end of this talk. As Dr. Ibrahim mentioned, hearing loss is a very frustrating thing you can actually face. Just imagine when you face parents and you have to deliver the news that their baby has no hearing at all. I've dealt with this problem many times, and believe me, it's not easy to accept and digest this fact. And imagine 50 years ago, at this point, we will tell the parents, sorry, there is nothing we can do. But alhamdulillah, luckily, with the advanced technology, with development of cochlear implant, now we can tell them, don't worry, we have an option. So this is my talk. The first part will talk about type of hearing, degree of hearing loss and causes, which I'm going to go through it in probably a couple of minutes, since already covered nicely by Dr. Ibrahim. And the second part would be mainly about the cochlear implantations. So normal hearing, again, was described nicely in the previous lectures. The sounds, let's just quickly go through it in a very simple language. Go through the ear canal, that will move the eardrum. The eardrum will move the ossicles, okay, or the middle ear bones. The middle ear bones will move the fluid inside the cochlea, and that's the cochlea. Okay, the pointer is not working, but anyway, so the cochlea, and then the cochlea will transmit signals to the brain through the auditory nerve, or the 8 cranial nerves. Type of hearing loss, there is 3 main types: conductive, the problems in the ear canal, eardrum, or the middle ear cavity; sensory neural, the problem inside the cochlea or the nerve of hearing, or mix of both. Okay, so anything actually in this area or in the first part of the ear canal, tympanic membrane, or the ossicles would be conductive, and the other parts would be sensory neural. Sensory neural hearing loss, meaning there is a problem inside the cochlea itself, and that luckily is the most common problem we face as a sensory neural. Less patients will have a nerve problem, and that's what we call neural hearing loss. In most of the type, or most of the sensory hearing loss, the problem inside the hair cells inside the cochlea. So basically, the signals are not transmitted from the cochlea to the nerve of hearing, and that's what becomes the function of the implant to bypass that defect. So let's again talk about very important facts about sensory neural hearing loss, which is the main topic about, or the main cause of hearing loss in patients who needed cochlear implantations. So it's around 1 to 3 in every 1,000 live births. It's more significant with neonates with risk factors, as again discussed with Dr. Ibrahim. For example, immaturity, hyperbilirubinemia, patients or infants who needed antibiotics, intubations, ICU admission for a few days. Those actually are at higher risk of sensory hearing loss. Genetic cause, more than 50% of the time. Acquired cause, again, different in infections, anoxia, low birth weight, and others. And sometimes we cannot find any reasons for the hearing loss, in around 15 to 30%. Degree of hearing loss was also discussed by Dr. Lubna. So the normal hearing, anything above 20 decibel or 25 in some references. But when we talk about severe or profound, we are talking about very, very difficulty hearing or deafness almost, where people cannot even hear very loud sounds like loud of cars or machines. That's considered severe or even profound. So why it's important? Why this topic is important? Deafness in pediatric age group adversely impact language. So if we cannot hear, we cannot talk. We cannot develop a language. And definitely will affect the educational and also social, emotional development. So hearing is very, very important to develop those skills. So in management, how we manage those patients? As we again divided hearing loss in different degrees. So mild sensory hearing loss to even type of severe hearing loss can manage successfully with hearing aids. So we fed patients with hearing aids. They can hear very well and problem solved. But what about profound hearing loss, where patients are not even getting any benefit from hearing aids? That's a problem. Here comes actually the options of cochlear implantations. So we finished the first part of my talk. Now we will move to the next part, which is management of severe to profound hearing loss resulting from cochlear damage. So cochlear implant. Cochlear implant, probably nobody can disagree that it's the most advanced technology have ever been created in ENT field. It's definitely changed the field of otology significantly since it was invented. I have actually probably a 45-minute talk about the history of cochlear implants. It's just fantastic to hear. Just to give you an example, the first implanted device was only a wire in the patient's ear. So patient had no tympanic membrane. He only had inner ear, no ossicles, nothing. And a physician decided to put a wire and connect it to the wall. Definitely he has an electrical shock, but the interesting news, he could hear something. That was actually in the 60s or even 50s. And that was probably the first sign of we can get some hearing back from electrical techniques. So what is the cochlear implant? So basically it's a electronic device. It's a hearing aid, but it's implantable. So we have to implant it inside the body. By implanting the implant inside the cochlea, we are bypassing everything before that. We are bypassing absence of canal, for example, no tympanic membrane, no ossicles, nothing. So we bypass all that and we stimulate directly the hair cells of the nerve of hearing. So cochlear implant can provide a child with useful hearing. It improves communication significantly. It's a very safe, reliable, and effective treatment for profound hearing loss. So kids born with no hearing at all, they can actually develop almost normal life and normal education. So what are the components of cochlear implant? There is two components. One, on the right side is the implantable one, implanted inside the ear surgically, and the external part, which is worn behind the ear. Okay, so that's the processor and the magnet in addition to the microphone. And that's what it looks like after it's completely finished or implanted. So that's basically the external part, the processor, the microphone, and the magnet, which transfers the signals inside the implanted to the implanted part. So how the implant works. First, the microphone, which actually pick up signals. Then the signals will be processed, coded, and sent through the FM transcutaneous system to the implanted part. The implanted part will actually decode the signals again and send it to the multi-channel arrays to stimulate a specific nerve ending inside the cochlea, and then the nerve of hearing will be stimulated, and the signals will be sent to the brain. So that's what it looks like in real life. So there is the external part, which is connected here, and this is just imagining the inside part, where the multi-channel array going inside the cochlea. So indication of implant. So for example, for sure, we actually only implant very severe to profound sensory hearing loss. And they have to try hearing aid first. So we have to document that there is no hearing improvement after using hearing aids for at least 6 months. Patients should be medically able to tolerate cochlear implant surgery. So there's some kind of contraindication sometimes to use implants. We have to discuss this with parents. They have to have realistic understanding of the surgery, the benefits, the risks, that it's actually long-term commitment. They have to follow with speech therapy. So it's not just the surgery and that's it. So the after surgery is even more important than the actual surgery. So the implant process. So first we start with what Dr. Lubna mentioned. We assess for hearing. We have to document that the patient has no useful hearing. Patient has to try hearing aids and usually have no benefit of hearing aids. And then we actually do some further testing, sometimes for older kids or adults. Sometimes we do even speech and language testing as a baseline. Then we evaluate patients for medical health issues, make sure that he can actually undergo surgery, general anesthetics with no problems. We do imaging to confirm that there is cochlea, there is a nerve of hearing, as Dr. Ibrahim mentioned. Sometimes the patient has no cochlear nerve at all. So at that point, we cannot even implant those patients. So we have to investigate with CT and sometimes CT and MRI, make sure that the patient has no contraindication for the implant surgery. Pre-implant psychological evaluation is also another full hour talk. We have to make sure that the parents have a realistic understanding of the process, what the expectations. We've seen tons of parents that after surgery, they decided not to use the implant for reason or the other. For example, some of them say it's too much work. We have to actually take our kids to speech therapy almost every week in the first few months. They need special education at first. They need a lot of attention in the first few months. So it's definitely a challenge to the whole family. And they have to understand that and accept it. Then we move to the surgery. Surgery is a relatively simple procedure. It's not that hard. It can be done in 1 hour, sometimes up to 2 hours under general anesthesia. We usually perform a small 4 centimeter post-auricular incision, and then we drill the mastoid bone, a small mastoidectomy, a small hole, which we call facial recess, where actually we pass the multi-channel array to inside the ear. And we put the receiver stimulator behind the ear in a small pocket. This is what we call, again, round window approach. We actually expose the round window, which is part of the inner ear, and we introduce the electrode inside the cochlea. After 3 to 4 weeks after the surgery is completed, the patient actually brought to the hospital and wear the processor, which is the external part. And then we connect the processor to special computers, special software, and we start mapping the signals till we make sure that the patient hears comfortably, not too loud and not too soft. So the mapping itself, it's a long process that the audiology has to go through with the kids in the first few months till we make sure that the kids actually hear what we suppose to let them hear. So activation of cochlear implant is very, very emotional moment. I've seen it many times in adults. Just imagine, as Dr. Ibrahim mentioned, the silence they live in for a year or more, and then suddenly they start hearing back. So it's definitely emotional moment. I'll give you this just an example to see. So this lady, she lost hearing for a few years, and now we are activating the implant.
We're going to pray over it. There you go. Beeping. So now technically your device is on. There you go. Oh, it's exciting. You can put it down for a second. Just to use the sound. Oh, you're messed up, guys.
So indeed, it's emotional. It's emotional moments when patient can have his sense of hearing back. And even way more exciting when you see kids. They never actually respond to sounds, and then suddenly, when you actually activate the implant and you start, especially when the mom talk, they start looking at her for first time, they are hearing their sounds or their voice. It's really, really emotional and exciting for sure. So let's conclude, and then I'll share with you another thing. So cochlear implant restores some sense of hearing, but it's nowhere near the hearing sensation that produces in a normal ear. So definitely we cannot mimic what God gave us. But for patients who cannot hear anything, this is fantastic surgery and fantastic experience. It improves the ability to understand speech. So it's not just understand sounds. They can actually understand speech very well. And the study now is overwhelming. We have thousands of studies to show the benefit of cochlear implant in kids, in adults, and even elderly. So before I conclude, I want to show you something. A lot of you probably ask, how is music actually can be heard with cochlear implant? It's definitely not the best, not the greatest, but it's different from person to person. Some people enjoy music very well. In fact, we did studies that show cochlear implantees sometimes can enjoy music almost as normal as normal hearing. But just to give you an example of how some of them can hear music.
Will your mouth still remember the taste of my love? Will your eyes still smile from your cheek? Darling, I will be loving you till we're 70.
So for sure, for all of you, you're going to say it sounds terrible, and that's true. But actually, with training, this is improved, and not all of them hear music like this. This is actually came from people who were implanted from one side, and they can actually tell us what they hear when they compared normal to abnormal ears. But actually, this is improved with time. And as you notice, the first song, the Ed Sheeran, it wasn't very nice because the cochlear implant does not transmit the sounds of the singer as well as the melody very well, but actually transmit the rhythm as Michael Jackson song much better. But anyway, technology is improving. Just imagine, in 50 years ago, we implanted patients with just a wire of electricity, and now we are implanting of 32 channels. And every time we increase the channel, we actually improve the sounds. So that's another, just a simple example to understand what we mean by channel. So this is the first implant, for example, one channel. However, when we move to 8 channels,
this is an example of a 6-channel processor. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. This is an example.
so the technology is improving. And another 20 years, I don't know, we probably could hear almost back to normal. That was my last slide. Anyway, I'm sorry for, again, keep you waiting, and it's almost 11. But I hope you at least enjoy our
والله يا دكتور جزاك الله كل خير. Subhanallah, and this will remind all of us that we cannot count the God grace. وإن تعدوا نعمة الله لن تحصوها. Dear friends and colleagues, now we reached already to the end of the webinar. Let's manage the question if you have any. I have one question from Dr. Hussein. Dr. Hussein is asking if the sedation test can cause the dimension of brain auditory evoked potential waveform, for example, wave V, etc. Dr. Lubna?
Sedation cannot يعني don't affect the waveform of auditory brain evoked potential.
Dr. Hamada, he said, thank you very much for this presentation. And for me, from my side, I just want to thank our great speaker, Dr. Lubna, Dr. Ibrahim, and Dr. Hussein. Thank you very much for the very informative and to-the-point presentation, especially about the cochlear implantation. It was very interesting, Dr. Hussein. Thank you very much. Thank you, Dr. Daniel. Thank you, Dr. Long. Another question came. Dr. Hussein, he is thanking all the speakers. Thank you very much. So, dear friends and colleagues, thank you very much for joining us to this webinar tonight. Wish you all the best. Again, thanks for our great speaker, Dr. Lubna, Dr. Ibrahim, and Dr. Hussein. شكرا. السلام عليكم ورحمة الله وبركاته. شكرا يا فندم. الله يخليك. تسلم.